Hi everyone, this is Dr. Sandeep Sharma here. A Neet PG exam has just been held, and since I'm traveling, I don't have access to a lot of equipment, but still I'm recording a quick recall session based upon whatever students have shared. I'm not going into the details, but you will get an idea how the questions were, and obviously, if the recall changes, then if the options change, the likely answer is also going to change. So this is only based upon active recall done by the students. Regarding peculiarity in the exam, there were multiple questions asked from topics like vitamins, on errors of metabolism, trauma, RDS, etc. And a lot of overlap was there. Like there was significant overlap, significant integration between pre and para subject as well as the clinical subject. And long stem questions were not too many. Most of pediatrics was solvable except one or two questions which were slightly tricky. So let us go into the discussion. Let us start with question number one. So question number one, it's a repeat question. So students, mark it, it is a repeat question. If you have been thorough with the last 3-year papers of NEET PG and INI-CET, you would have found similar question in the exam. The question says, a 3-year-old child came with fever, difficulty in breathing and stridor. Some students said stridor tha, some students said कि sir biphasic stridor tha, doesn't change the question. And preceding upper respiratory infection history is present. So viral prodrome followed by fever, stridor, sometimes often associated with barking cough. Barking cough was not mentioned in this question, but instead they give a X-ray of the neck, and X-ray of the neck is showing subglottic narrowing and broadening of the airway as it is coming down. This is the so-called steeple sign. So steeple sign is a repeat question. Steeple sign, likely diagnosis in the patient, yes, it is going to be croup. Croup is also called as acute laryngotracheobronchitis. So answer to question number one was croup. So remember that acute epiglottitis will have a thumb sign, also called as thumbprint sign. Acute epiglottitis will have fever with stridor, but there will be no preceding viral prodrome, and there will be a acute onset of the symptoms. In acute epiglottitis, also remember that there will be drooling of the saliva. Sometimes if the distress becomes severe, the child may sit and breathe in a tripod position, right? Laryngomalacia does not present like that. It does not have fever in it, and glottic foreign body, obviously, it will not have a fever and preceding upper respiratory infection, etc. So question number one, the answer is D. Let's move further. Question number two. 28-week premature neonate developed respiratory distress soon after birth. Any preterm child less than 32 weeks, if there is distress soon after birth, you always suspect RDS in the patient. RDS is also called as hyaline membrane disease. RDS and HMD occurs due to deficiency of surfactant. So this question is indirectly asking you what is the most important component of surfactant. The likely cause is deficiency of C. Surfactant has multiple things. It has lecithin, it has phosphatidylglycerol, it has proteins, it has cholesterol, water in it, but the most important component is lecithin, and that is what the answer is. Lecithin is also called as DPPC, that is dipalmitoyl phosphatidylcholine. So if lecithin was in the option, that would have been your likely answer. If that was not there, then the next logical answer will be phosphatidylcholine, but only when lecithin is not there, because phosphatidylcholines can be of multiple types. They can be saturated, unsaturated, and with or without a palmitoyl base attached. So lecithin, DPPC is the most likely answer here. And what does Nelson say? Nelson says, look at this, what Nelson is saying. The major constituents of surfactant are dipalmitoyl phosphatidylcholine or lecithin, followed by others like phosphatidylglycerol, apolipoproteins, and cholesterol. Right? So the answer is very clear here. Let's move further. Question number 3, again related to RDS. So if RDS had been prepared well, you would have got 2 questions correct. In a 28-week child with suspected RDS, what of the following occurs? You know that in RDS or HMD, there is deficiency of surfactant, right? Surfactant deficiency causes unopposed surface tension in the alveolus. So there is a collapse of the alveoli. This collapse of alveoli reduces the distensibility or compliance of the lung. So if there is no surfactant, what will happen? Surface tension बढ़ जाएगा, compliance कम हो जाएगा, right? So what does Nelson say? Nelson 21st edition says surfactant deficiency is the primary cause of RDS. In the absence of pulmonary surfactant, there is significantly increased alveolar surface tension. उससे क्या होता है? Collapse of alveolus, atelectasis will happen, right? FRC will be reduced, it will be impaired, and alveolar atelectasis will make the lungs less compliant. So compliance will be less, surface tension will be increased. So answer to this question is B. So it's an indirect repeat question and kind of overlap between pediatrics and physiology, right? Let's move to question number 4. Easy one-liner type of question. Sweat chloride levels are used for identifying which disease? Yes, the answer is cystic fibrosis. Cystic fibrosis is a condition in which there is a gene mutation of CFTR. Chloride channel nahi banega. Chloride channel in respiratory tract, GI tract, it has a tendency to secrete chloride. On the other hand, in sweat gland duct, it has a tendency to absorb. अब sweat gland में नहीं है, chloride absorption will not happen. So what will happen? Chloride will be lost into sweat, and so there will be excessive loss of chloride. That is used as a test. Nelson 21st edition says कि patients who are having cystic fibrosis, you will do a test known as sweat test, also called as sweat chloride test. It involves pilocarpine iontophoresis. You collect the sweat, and you check for the chloride content. And what is the cutoff? For future MCQs, remember, if the sweat chloride test shows 60 milliequivalent per liter or more of chloride content, we would say the patient is having likely cystic fibrosis. It is used as a screening test for cystic fibrosis. So अगर question पूछे कल को screening test for cystic fibrosis, it will be sweat chloride test. Remember that sweat chloride test is screening test in all age groups except infants and young newborns. In newborns and young infants, you go in for immunoreactive trypsinogen assay, but that's beyond the discussion here. Let's move to the question number 5. Which among the following is correct regarding normal growth in a well-nourished child? Now the exact options have not been recalled, but I was able to recall at least A and C option correctly. So if you know the correct answer, you know the correct answer. This question is based upon anthropometry. Many times questions on anthropometry are difficult, but if the question is asking correct or incorrect thing, whatever you know, and if that correct option is there in the question, you can easily reach the correct answer. Now, in any pediatrics class, wherever you have read, you must have read that when you talk about length of a child, at birth, the length of a child is about 50 centimeters average, right? At 1 year, it becomes 75 centimeters. At 2 years, it becomes 87.5 to 90 centimeters, and 4 years, it becomes 100 centimeters. This entire thing has been asked multiple number of times in various ways, and this option, question number 5, option number A, if you see, length increases by 25 centimeter in first year of life. So first year of life में 1 year first birthday जब complete होता है, length increase how much happens? It is 25 centimeter, and that is the correct answer. Regarding other options, birth weight increases by 300 gram every month. That is not correct. Please remember that initially birth weight declines in the first week of life. Then around 10th day of life, weight of the child becomes equal to birth weight, and then the child starts gaining about 20 to 40 grams per day till 3 months of age. Only beyond 3 months the child starts gaining about 400 grams of week per day. It is not 300 gram, it is 400 grams, that too after 3 months. That pattern, I'm not writing it here because the video बहुत लंबा हो जाएगा. I don't want to prolong this discussion, but it is mentioned in your notes, and that is why option number B is not correct. 33% increase in birth weight in 1 year is also not correct. Option D was not recalled, but even if the option D is not there, and if option A was just like that, it has been mentioned, 3 or 4 students said कि sir almost यही option था, so the answer is likely to be A, right? So anthropometry पे question आया है. It was not easy. If you have got it right, trust me, you have done well. Then question number 6. In a 5th class student aged 10 years, which vaccination should be recommended? It's a repeat question, indirect repeat question. National immunization schedule they are asking. In every exam there is a question from vaccination, national immunization schedule. So the national immunization schedule says at 10 years you will go for TD देंगे, right? पहले ये TT होता था. Now it is TD, tetanus and adult diphtheria. So the reduced amount वाला जो diphtheria component है, that has to be added. Further, the NHM guidelines also says that TD needs to be given at 10 years and 16 years. Dose is 0.5 ml. Intramuscular देंगे, and upper arm it has to be given. So answer to question number 6 is A. Moving further, let us look at question number 7. Question number 7 is showing an image. It occurs due to deficiency of which vitamin? This child, as you can see, is having bow legs, right? Bow legs. And bow legs are a feature of, obviously, rickets. It occurs due to vitamin D deficiency. So there are two things that you should remember for future exam. You have genu valgum and you have genu varum. Valgum में knock knee होता है. Both the knees are touching each other. Valgum, gum. Gum means the knees tend to stick together. Gum knees को जोड़ देता है. they tend to stick together. So knees close together is genu valgum, and genu varum, rum. Rum means alcohol. Alcohol makes you unstable, and the gap between the two knees tends to increase. So again, these children are not drinking rum. What I'm trying to say is a stupid way of remembering that knock knee is genu valgum, where the knees are rubbing against each other because the gum is causing them to stick together. This is how you remember. And bow-legged is genu varum. Both can be seen in rickets. Sometimes a combination of the two can also be seen, which can produce the so-called windswept deformity. So windswept deformity can occur in hands in rheumatoid arthritis, and in rickets they can involve the lower limbs also. But more common manifestation are the bow legs. Moving further, question number 8, a child develops fever with rash. The pediatrician noticed koplik spots in the mouth. Now fever with rash, there can be 1,000 diagnoses, but if the question says koplik spots are there, they are rice grain like lesions, the likely diagnosis in the patient is measles. It's an easy one. This is the typical rash. So remember, whenever you have a child who's presenting to you with fever with 3C, what are the 3C? Cough, coryza, conjunctivitis, right? Running nose, stuffy nose, cough, and inflammation of the eyes. And the child develops a rash. The typical rash in these patients is a non-itchy, fine maculopapular rash. MP is maculopapular rash. And it starts and it appears on the face and goes to the trunk. This is the typical progression of the rash. Along with that, there is a enantheme also. What is enantheme? A mucosal lesion typically called as koplik spots. It's a past नीट पीजी क्वेश्चन 2020 में पूछा गया था कि कॉप्लिक स्पॉट्स कहाँ दिखते हैं. They appear earliest and most commonly they appear opposite lower second molar tooth. As you can see in the image was not there in the question, but obviously this is a potential future question also. So rice grain like lesions which are present, bluish white in color with surrounding erythema, appear opposite lower second molar, but they can spread over the other parts of the buccal mucosa as well. So answer to this question is measles. It's an easy one. It's a repeat question. Question number 9, again indirect way of asking a repeat. Child at birth has sensorineural hearing loss, diminished vision, and a heart defect. Some students said PDA tha, some said ki PDA nahi tha, only heart defect was mentioned. Likely organism causing this. This is the typical triad produced by congenital rubella syndrome, where you have deafness in the patient due to sensorineural hearing loss, you have cataract in the patient, which is causing the decreased vision, and you have congenital heart disease in the patient, that is most commonly patent ductus arteriosus. Other diseases can also occur. So answer to this question obviously is rubella. Moving to question number 10. It was a long case. Thank you to Dr. Ribhav and Dr. Manoj for giving me such a proper recall after the exam. So a female delivered a 1.2 kg baby prematurely at 31 weeks. Child has hepatosplenomegaly, jaundice, petechial rash. Child failed neonatal hearing screen, likely sensorineural hearing loss. CT scan showed the hallmark condition, periventricular calcification. I always say periventricular calcification milega, infection suspected hoga, the likely diagnosis is always going to be congenital CMB in the patient, and answer to this question is congenital CMB. Again, it is a repeat question. So if you see last tino question, they are repeat questions, right? Not direct, but obviously indirect repeat. So this is the typical periventricular calcification. A potential image can be asked in the exam in the future. Moving further, question number 11, tougher question. Infant has paroxysms of nocturnal cough. रात में cough होता है with fever. The child also has chest retractions, gasping, and cyanosis. TLC is 50,000 with lymphocytosis in the patient. What is the management? First, you need to make the diagnosis. Paroxysmal nocturnal cough. If it is associated with fever, even if fever is mild in nature or absent, paroxysmal nocturnal cough with a raised TLC should raise the suspicion of pertussis in the patient. Pertussis, if it happens in infancy, it is more severe. It shows absolute lymphocytosis, and the child has gasping effort. The child has episodes of cyanosis, episodes of apnea following a cough. And cough के बाद vomiting होना is also very common. Whoop is characteristically absent in this age group, and that is why the word whooping cough is no longer, favored to be used, particularly in younger children. So everything pointing towards pertussis. What is the management? Yes, the drug of choice in pertussis, according to both Nelson 21st edition as well as IAP Pediatrics 2022 guidelines, India में अभी release हुआ है नवंबर में, अक्टूबर में, the drug of choice is azithromycin, both for prophylaxis and for treatment now azithromycin is to be favored. The examiners wanted to check, it was a tougher question, but the answer to this question is azithromycin. Chest retraction क्यों है? Some students said कि सर ये pneumonia तो नहीं हो रहा. Yes, pneumonia might have happened. Pneumonia अगर हुआ है, pneumonia is a known complication of pertussis. Drug of choice remains the same because it is caused by bordetella pertussis. Secondly, chest retractions can sometimes be a feature of the gasping effort, and it can be a part of the general illness in the child also. So pertussis patient, I've managed a pertussis patient in my residency, and we were quite perplexed to see the patient कि इसमें भूख तो होता नहीं है, all these other features are present. So if you find a patient, if you see a patient like this, it was a tougher question, I agree, but the likely diagnosis is pertussis. They have given a lot of clues. Everything is pointing towards pertussis in this patient, and for that the drug of choice is azithromycin, right? Question number Now question number 12 says golden colored rings in eye are being evaluated. Which investigation should be done? Look at the options. They are talking about the mineral deposition. So which mineral deposition in the eye can cause golden colored rings? Yes, you are right. It is likely to be Kesher-Fleischer rings. KF rings occur due to deposition of copper in the Descemet's membrane of cornea. It is strongly associated with neurological involvement of Wilson's disease. So the likely diagnosis in the patient is Wilson disease. And for Wilson disease, which is the screening investigation that you do? Yes, we do serum ceruloplasmin in the patient. So screening is ceruloplasmin. If it is low, if it is found below 20 milligram per deciliter, you should suspect Wilson disease in the patient. So tomorrow they may repeat the question. Instead of asking like this, they may put up an image like this. So this is the typical Kesher-Fleischer rings which are there. Wilson disease is again a high yielding topic. Medicine may be important here. It is important in pediatrics also. So if you have read it well, you have a high likelihood of encountering this question, this topic. And this topic is also asked in INI-CET exam. So for those of you who will be targeting the May exam, because counseling is going to be delayed, you know the reason for that. If you have done the exam well, and even if you have not done the exam well, you don't have a choice. Please be serious, take a break for a few days and get back to reading Wilson disease, congenital infection, vaccines, IEMs. They are important. You have seen the Neet PG exam, they're going to be important for your INI-CET also. So question number 12, the answer is A. Moving to question number 13, it's a repeat question. It's a repeat question. Scurvy with delayed wound healing, likely cause. The answer is collagen synthesis defect. I don't have the other options which have been recalled, but collagen synthesis defect was there. Scurvy happens due to vitamin C deficiency. Vitamin C or ascorbic acid is required for hydroxylation of lysine and proline residues, which stabilize the collagen structure. So if vitamin C is deficient, the collagen synthesis is not proper, and that is why these children have delayed wound healing and loose gums and all the manifestations. Moving to question number 14, difficult one, tricky one, child with DKA case. There is a reason this question has been put, because in October 2022, new guidelines, refined guidelines for DKA in children have been released. So there was a child with DKA, what I have been told, there was acidotic breathing in the child, arterial pH was 7.2, dehydration and urine 3+ for ketone with very high blood glucose 550 milligram per deciliter. What is the management? Now, I'll not go into the details. I'll simply jump to the protocol. This protocol, please add it to your notes for future exams also. It is going to be helpful how you are going to do the initial DKA management according to ISPAD guidelines. So whenever you are suspecting DKA in the patient, in case the patient is having minimal dehydration and tolerating oral fluid, you give oral hydration along with subcutaneous insulin, right? In case patient is dehydrated but not in shock and acidotic and vomiting, you will start with saline therapy. Single bolus will be given. Normal saline 10 ml per kg will be given over 1 hour, right? And also see that you will add KCl per liter fluid. You will correct the remaining fluid deficit over 36 to 48 hours. तो bolus एक ही देंगे and continuous insulin infusion देंगे. Insulin is not given as a bolus. Bolus insulin paradoxically worsens the patient. And आप start करेंगे insulin 1 hour after the fluids have been initiated. So only when the saline therapy is over, you will start with insulin infusion. Many times by giving fluid alone, you will find that the patient's blood glucose starts improving a bit, and insulin then comes into only a supporting role in that. Just like, you know, Saif Ali Khan was the supporting actor in Kal Ho Na Ho. Shah Rukh Khan was the main actor. This is your Shah Rukh Khan. If it is a Kal Ho Na Ho, stupid logic always works. So saline or Shah Rukh Khan will always be the initial therapy. That is the most important thing. After that is over, you will start with insulin, and that should also be given slowly in the patient, right? And in case the patient is having shock, then obviously you will have to do airway breathing circulation, and in circulation the bolus, two boluses are needed. So up to 20 ml per kg you will give in the patient, and along with that obviously the remaining management I have not discussed. Now go back to question and try to see. This patient is having dehydration. Even if you have dehydration, even if the patient has shock, you don't start with 20 ml per kg. The current consensus is you give 10 ml per kg bolus and see the response and then repeat if it is needed. So the answer to this question is normal saline you will give at 10 ml per kg, and after 1 hour you will give insulin. So C option, normal saline 10 ml per kg over 1 hour with insulin given later will be the option. Now I don't know the exact option kya the. You have given the question, but I hope you understood, and now you can make out whether the option you marked was correct or not. Moving further, question number 15, easy one. Child is passing dark urine. What should you suspect? Dark urine happens because of the pigment deposition. It's a IEM associated with homogentisic acid oxidase deficiency. There is accumulation of homogentisic acid which gets oxidized, leading to the typical dark urine, and you have alkaptonuria as the likely diagnosis. It is a repeat question. How many times it has been repeated? At least 3 times in one way or the other in the last 5 years. You can, if you have spare time, you can go and check. So don't get questions like this wrong. Question number 16. Infant presented with progressive jaundice and pale colored stool. See, newborn or infant who's having jaundice but he's having pale colored stools, always suspect that the patient is having some element of cholestasis. Now look at biopsy. Liver biopsy revealed bile plugs and bile ductular proliferation. Likely diagnosis in the patient. This is the hallmark finding what we find in patient of extrahepatic biliary atresia. Nelson clearly says that biliary atresia is characterized by bile ductular proliferation, bile plugs, portal or perilobular edema, and fibrosis in the patient, with the basic hepatic lobular architecture being intact. बाकी options क्यों नहीं है? Crigler-Najjar syndrome causes unconjugated hyperbilirubinemia, and these patients will not have a pale colored stool. They will have normal colored stool. They have unconjugated jaundice. Dubin-Johnson syndrome will have a, when you do liver biopsy, you will find a dark liver in the patient. Plus, these patients do not have a progressive jaundice. Dubin-Johnson syndrome comes to attention usually later in life, and it causes a relatively mild jaundice. Without taking any name, one of my MBBS batchmate does have Dubin-Johnson syndrome, and he's leading a very normal life, proper life. He's a good consultant. I'll not go beyond that. So Dubin-Johnson syndrome less likely to present like that, and extrahepatic biliary atresia is the most likely answer here. Extrahepatic biliary atresia, also remember that because this jaundice, this proliferation of bile ducts is progressive, eventually you need to do liver transplant in the patient if early surgery within 2 to 3 months is not done, and that is why EHBA is also the most common indication for liver transplant in children. This is a past NEET PG question also, right? So answer to this question is C. Question number 17, delayed wound healing, diminished vision, perioral rash. Perioral rash कुछ बच्चे कहते नहीं था, कुछ कहते था. Diminished vision because of involvement of conjunctiva, there is conjunctivitis and corneal ulcers in the patient, and delayed wound healing along with anemia, diarrhea, etc. It is seen due to deficiency of zinc deficiency. In fact, all these three features along with alopecia are the characteristic features which are mentioned in patient of acrodermatitis enteropathica. And वो कौन करता है? वो zinc deficiency से होता है. So delete, even if that word is not mentioned here, all of these features are pointing towards the zinc deficiency in the patient. Zinc is required for skin as well as epithelial mucosal integrity, and that is why you will have rashes, you will have the anterior structures of the eye getting affected, particularly conjunctiva and cornea. Now there were other overlap questions with biochemistry also, but I'm not going there. Like there was a question on biotin deficiency, raw egg consumption, avidin is there, so that will cause. But I did not have the adequate recall, and they are more biochemistry than pediatrics, so I'm not encroaching upon that area. But lot of vitamins and IEM related topics was. But there was a question on Tay-Sachs disease also. This was an intriguing question. This is a more pathology than pediatrics, but I need to share my pediatric aspect here, and that is why I'm mentioning it is pathology with pediatrics overlap. Recall the question was 5-year-old child with cola colored urine, right? Mild facial puffiness, raised serum creatinine more than 2.2 persisting at 3 weeks. Pyoderma was there 3 weeks prior to this. electron microscopic finding you will expect. Now this child, if you look at the entire clinical picture, it is likely to be post-streptococcal glomerulonephritis. In patients of post-streptococcal glomerulonephritis, what you find is the subepithelial deposits on electron microscopy. Subepithelial humps is the typical finding. Now, many of the students marked crescents in the option, saying कि sir crescent is crescentic GN, RPGN का type 2 के अंदर one of the reason is PSGN. Yes, it is there. But you need to understand that PSGN is a rare cause of crescentic GN. Second thing is, this question is saying कि अभी इसके अंदर there is nothing to suggest the patient is going into RPGN. You will suspect RPGN if there is a rapid worsening happening in the patient, or there is low azotemia, oliguria, this raised serum creatinine persisting more than 6 to 8 weeks. Normally, PSGN continues till 6 to 8 weeks and then there is a rapid recovery in the patient. So in this question, the more likely diagnosis, the more likely answer, according to, if you ask almost any nephrologist, would be subepithelial deposit. It is the better answer. One of my close friend and as well as colleague, she's a pathologist, and I discussed with her and she was very candid in that. She said PSGN, if the same question comes, I would safely mark subepithelial deposit. But if the same question says serum creatinine from 2.2, it has jumped to 8.2 or 9.2 within a few days, or this is persisting at 7, 8 weeks or 9 weeks or 10 weeks, then you would suspect that crescentic GN has now set in as a complication in the patient, and there the answer will be crescent. Why the answer is less likely to be crescent here also? Because they are asking about the electron microscopic finding. If this word was mentioned again, the likely diagnosis is going to be subepithelial deposit. It's a controversial thing, and I wanted to share my perspective on this, and that is why I've included it here. So takeaways: vitamins, pediatric infections, IEM had huge weightage. Congenital infection is expected 2 to 3 questions. RDS, neonatal jaundice, it was conjugated this time. Anthropometry was asked. CF always asked. This was easy this time. No diarrhea, no CH, no milestones. 2 to 3 repeats from past papers and some difficult clinical questions, especially that DK question. But pediatrics mostly was solvable. I hope you benefit from it. Please ignore the poor quality of the light and the video image here. I hope you get the gist of what I wanted to discuss. Thank you so much for your time.